Well, thank you very much, Francisco, for the introduction, and thank you all for your attention initially. Hopefully it will keep. So basically with the title of this session, it comes repeatedly in this presentation because there is still quite a lot of people who question within MSF, Central America, yes or no. So how far should we go, Central America, yes or no? Then the other one is sexual violence, yes or no, vertical programs for sexual violence, yes or no. And the final one would be coverage, yes or no. Should we go for coverage in these programs or just provide the services? So I will try somehow to answer some of these questions. So why did we do this thing? I mean, what was the rationale for us going to know a little bit more of sexual violence? Sorry, yeah, I tend to move. So we did with this mixed method a study with quantitative, with a cross-sectional survey and with a qualitative part to it, to really understand a broad sense of issues. So we had sexual and reproductive health, we have violence, we had mental health. But here I'm going to focus basically on the sexual violence part because this happened after 4 years of service provision. So after 4 years of service provision, what we saw is basically this pyramid that repeats all over with the programs focusing on sexual violence or on violence in general. So we only tend to see the tip of the pyramid, right, in the reports. So we see how many people have been killed after a sexual assault, and in Guatemala it's close to 500 in 6 months in 2011. Then we can also have access to the number of rapes reported to the police, and we see it's close to 6,500 in the same time period. And if we're lucky enough, we can go and see how much rape is reported in general population surveys. So we see that in Guatemala City it was nearly 9% lifetime prevalence. And also we see this gray area of health service provision. These are the people that actually receive services during our work or with MSF services, who did receive services. So some of them reported rape to the police, some of them didn't. Some of them have access to the legal system and the medical system, some of them only to one of them. So we wanted to know what lied beneath these lines. Okay? We wanted to know the magnitude of the problem and why people were not seeking care, not all of them. So we decided to go for a cross-sectional survey, as I told you, in Guatemala City, in 2 areas of Guatemala City, in Zone 7 and Zone 18. This, in Guatemala, the homicide rate is huge already, right? It's like 41 per 100,000. Just to give an overview, that is 6 times whatever we will find in Europe original. So we decided to go to these areas that actually have like 40%, that condense 40% of the homicides in Guatemala City. So these are the no-go red zone areas in Guatemala City. So just to give you a brief overview, we had a representative sample of 1,200 people from these 2 areas. Most of them, 60% were female and 40% were male. We did this by going on only during the weekends to maximize the chances of finding whoever in the household we wanted to interview. When I say whoever, it's because we didn't interview all the people in the household, but only those who had their birthday last, through the last birthday method. So you go, you ask how many are eligible, and you select the one who had their birthday last. With a median age of 33, we were interviewing people from 14 to 55 years of age, most of them Catholic, Hispanic origin, Latinos, with secondary education and living in households higher with more than 5 people in the household. So, what did we see in terms of violence? This is just sexual violence. What is a war tax and what is the health tool of this war tax? War taxes are called what the gangs charge people. This is a sense of extortion that is happening. So they actually call it a war tax. This is just to put in perspective what is happening there, okay? We are very reticent, in general, the international community is very reticent to call whatever is happening there a war or a conflict. ICRC is really struggling their head on how to call these things, but it's really the levels of violence that we're seeing are higher than in most of war situations. So we see, on that side, we see the female prevalence and the male prevalence. And we are talking only about 1 year period prevalence. This is, for me, this is just crazy. We saw the data last year. They were even crazier, but because we were focusing on a most at-risk population. We were talking in Honduras of a street-based population. This is just the general population. If we see that female between the ages of 18 to 29 are 7%, 7 out of 100 reported having suffered severe sexual violence, which is an event of rape or an event where they were forced to observe somebody being raped. That is just crazy from my perspective. And if we go to any type of sexual violence, it's close to 1 in every 4. We saw a significant difference, and women being between the ages of 18 to 40 being much more likely to report sexual violence. The adjusted odds ratio is 2.3. No surprise, the people in general were less likely to report sexual violence or to report events of violence to male interviewers. Okay, you say, well, why didn't you use only female as interviewers? Because these are really risky areas where the teams were safer if they were mixed teams. So, next one. I'm just including some of the quotes that we had during the qualitative part of the study. Here in Guatemala, nobody talks. Girls who are raped say nothing. It's rare to find one who dares. And then what you see are a row distribution of people who sought care and did not seek care by different variables. So you see by age, it is more likely for people over 40 and people under 18 to report. The under 40 is kind of strange for me. We will have to look deeper into this data. But under 18, it is likely to be conditioned by them being accompanied by their family. Most of the cases of abuse of people under 18 tend to happen within the household. Then you see a similar distribution for male and female seeking care. Indigenous people being more likely to seek care. And then something that is quite interesting is that the distribution of people in terms of the level of schooling that they have doesn't differ much between those who have no education and those who have university level education. And we can go into explanations. So another quote, kidnapping, torture is much more severe. Person ends up more damaged emotionally, psychological. Rape is something that happened to us women. It is something that you can get over from. This is just already the conception. This is the level of how sexual violence is normalized within this city already, because it happens so much. So just to go into the most interesting bits, I would say, you see that having received information in the last year on sexual violence doesn't seem to have an effect on people seeking more or less. And something that is interesting is that people who reported also, I'm trying to rush and then it's difficult. People who report also having suffered STI symptoms within the last year are more likely to seek services than those who didn't. And people who had suicidal thoughts within the last 4 weeks also tend to seek more care. This is an indication already for us that maybe having a vertical program only focusing on sexual violence might not be the best entry door for people. If they are already likely to seek services for other conditions, we should better integrate our services within those frames in order to capture as many people as possible. So, now we see how many are exposed, how many seek care, and among those who did not seek care, which are the main barriers. And we see something that is interesting here also. We see a difference between the barriers experienced by female and the barriers experienced by male. So mostly those experienced by female are the aims. So the blame, the shame, and the giving a family a bad name. Those are under personal judgment. And what you see in males is that basically what they report are service-related barriers. This is that they will not believe them and there is no use going for services. So we really need to be aware of the different gender barriers that are experimented in order to have different approaches to facilitate access. What did they say would have been helpful for them? 1 out of every 3 people considered that talking to friends and family could have been helpful. And 1 out of 6 that mental health counseling would have helped. Moving to the conclusions. What have we learned? So 1 year period prevalence of exposure to sexual violence in these areas of Guatemala City is extremely high. If we go only for rape, I told you that severe was mixed with another one. 3.4% of the women reported having been raped in the last year, and close to 1% among men. Only 38% of those reporting health consequences related to the sexual violence event sought medical care. So already the ones that you saw seeking or not seeking care is people who reported having suffered some kind of health consequence. Okay, so in theory, the percentage that we will see seeking care is higher because they already have identified a health need, but still it's quite low. Women reported experiencing more personal-related barriers to access care, and men more service-related barriers, and alternative points of care services are needed, mainly for adolescents. Why am I saying that? Because we need to explore the possibility to integrate service delivery modes, for example, with sexual and reproductive health, among unusual most at-risk population groups. When I say this is that we really need to have an open mind and go out a little bit of the African analysis of vulnerability or people who are most at risk. If we think of that in Africa, we might say, okay, women and children. If we think of this in Central America, we have to be very aware that we are going to be working with adolescents and young adults. Those are the people most likely to suffer violence and not to seek services. We also saw that doing this type of studies in red no-go areas in urban settings is possible. And the need to advocate for gender-specific and more community-based interventions to increase access to care. We saw that people would be willing to talk to family and friends. We need to incorporate these people in order to facilitate access. What are likely to be the next steps? We need to advocate for the continuity of care through MOH, incorporating these lessons learned. After 4 years of service provision, direct service provision, MSF is handing over the services to the MOH, so we need to advocate for that. And we really also need to incorporate this into our intervention logics in order to recognize this at-risk population and to incorporate services within integrated service provision or delivery modes. So just to finish, thank you all for your attention, and thanks to the participants that allow us a better understanding, and to the teams who actually went to these areas and gather the information. Thank you so much.